Register today for ACR Convergence 2024 and unlock one of the most influential meetings in rheumatology. Hear groundbreaking science and patient perspectives. Network with colleagues and mentors in the poster hall, the Global Rheumatology Summit, or the Ultrasound Conference. Join us for favorite events like the Knowledge Ball and the Thieves Market. Register today at rheumatology.org. ACR Convergence 2024, where rheumatology meets. Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shanmugam. Clinical trials in lupus are notoriously difficult to design, and our field has been plagued by many negative studies. However, today we're going to talk about a lupus trial that is sleek, both in its name and in its results. The manuscript we will discuss today is Efficacy and Safety of upadacitinib and elsubrutinib alone or in combination for patients with systemic lupus erythematosus, a phase 2 randomized controlled trial. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. It's really a pleasure to be joined by the first author of this study and a leader in the field of lupus, Dr. Joan Merrill. Dr. Merrill is a professor of medicine at the Oklahoma Medical Research Foundation and the University of Oklahoma. Dr. Merrill received her undergraduate degree at Vassar College and completed medical school at Cornell University Medical College in New York. She joined the staff of the Oklahoma Medical Research Foundation in 2001. Dr. Merrill is a master of the American College of Rheumatology and has received numerous awards for her work studying lupus, including the Edmund Du Bois Award and the Evelyn Hess Award. Dr. Merrill is a leader in designing clinical trials for lupus and is a champion of lupus cohorts. She currently runs the Oklahoma lupus cohort, which has enrolled hundreds of lupus patients. And she also directed the Biomarkers of Lupus Disease, or BOLD study, which demonstrated the importance of weaning background medications to show the efficacy of new medications in clinical trials for lupus, a topic I am confident she will discuss with us today. Welcome to the show, Joan.
Thanks, Vicky.
So let's start with some background about this study. We know that effective treatments for lupus are lacking, and in rheumatology, we're always looking for agents that will allow us to maintain remission and reduce glucocorticoid exposure. Tell us about the drugs involved in this clinical trial. Upadacitinib is an oral JAK inhibitor, and elsubrutinib is an oral BTK inhibitor. Why study them in lupus? And then tell us about the study drug, ABBV-599, which was a combination of the two agents. Why did you want to study the combination? And why did you look at two different doses of that combination?
Elsubrutinib is an inhibitor of Bruton's tyrosine kinase, and that's a signaling protein that contributes to basic activation pathways across different immune cells, especially B cells. But interestingly, doesn't really affect T cells. It also regulates cytokine production, and these are sort of some of the important cytokines that get a little excessive in lupus. There's quite a few BTK inhibitors out there. Most of the current ones that are being used primarily in oncology are irreversible inhibitors. So they form covalent bonds with Bruton's tyrosine kinase. Because of that, that can be associated with significant side effects. Now, there's also some reversible inhibitors in development. It's unclear whether they're going to be as potent or selective, but they might be less toxic. Elsubrutinib is something entirely different. It does form a covalent bond, so it's sort of like an irreversible inhibitor. And it has been found to be very potent and selective, but in this case, the covalent bond is reversible. So the treatment is thought to be potentially, the term they use is tunable for efficacy with a potential for limiting the side effects. Upadacitinib is a JAK inhibitor with specificity for JAK1. It's kind of one way you could place it is that it's a bit more targeted than baricitinib. It has, a little bit more of a focused mechanism of action. And it's hoped that this could lessen the risk for certain side effects, especially those associated with JAK2 inhibition, such as lymphopenia and neutropenia. But it has a somewhat wider spectrum than deucravacitinib, which finally targets another JAK that's called TYK2. And there's some overlap between JAK1 and TYK2 mechanisms. Both of them act at the inside of the type 1 interferon receptor, for example, and IL-10 receptor. So it makes sense that all three of these agents have been tested in lupus with the idea that when you sort of have an overlapping spectrum of activity, there might be differential use for maybe any of them. Now, the combination of two drugs, I think, is the most interesting thing about this study. It's quite unique in lupus. That's never been done, to my knowledge, before, to test two drugs at the same time. And the reason for that is that in lupus, we need more efficient trials. We've already got a complex disease, complex background medications, and this sort of ratchets up the size of a trial that's needed to see signals. So if you can test two drugs at once, that's more efficient. Also, there's almost no work in lupus that studies the pharmacokinetics and pharmacodynamic effects of drug combinations in lupus when we frequently combine drugs because the disease is hard to treat. We have very little idea in what ways these different drugs interact. I mean, we have a vague sense of their mechanisms, but it's, the immune system is complex. So we don't know when we put two drugs together, including doing a clinical trial with one drug and lots of background drugs, we have no idea whether these drugs are going to be additive, synergistic, or redundant, or maybe even do they fight with each other. So this clinical trial was innovative and would have opened the door to, at least with this combination, understanding a bit more about it and how they would work together. So I hope that there are going to be more trials like this to come. By the way, we do know that whether any drug works at all or whether two drugs work optimally together may depend in an individual patient on the dosing of each one. So maybe the question shouldn't be why were two doses tested, but maybe why can't we look at more doses and dosing combinations?
Yeah, that's a great explanation. And I agree. It is a way to certainly accelerate some of the advances for treatment of patients with lupus. So this was a phase 2 trial. It was designed to examine efficacy and safety. Tell us a little bit about the study design. How did you set things up?
Well, again, due to the fact that there was this notion of trying multiple dosing and multiple drugs, this would tend to enlarge a trial, but of course, a trial can't be infinitely large. So after a lot of consideration, 5 dosing groups were defined. 2 of the groups were combinations of elsubrutinib and upadacitinib. In both of those cases, elsubrutinib was given at 60 milligrams a day. These are oral drugs, by the way, so these are pills. So elsubrutinib was given at 60 milligrams. And then in one of those combinations, upadacitinib was at a lower dose of 15 milligrams, and the other upadacitinib was given at 30 milligrams. And so we call that the ABBV599 high dose pill, when the upadacitinib is a little higher. But in both cases, again, elsubrutinib is given at the same dose. Then there was a group who only received elsubrutinib 60 milligrams, and finally a group who only received upadacitinib at 30 milligrams.
And then you did have placebo too.
And the 5th one was the placebo group. That's correct.
Who was eligible to enroll in the study?
So first of all, patients had to be on stable background treatments. They could be on an antimalarial and/or no more than one immune suppressant and/or up to 20 milligrams of prednisone or equivalent corticosteroid. Mostly the people were similar to what you see in many lupus trials these days. They had to be between 18 and 65 years old, have a positive ANA or an anti-double-stranded DNA antibody or an anti-SM at screening. They had to have currently active signs or symptoms consistent with moderate to severe disease activity. The rule for that was that you had to have a total SLEDAI score of 6 or more, and the clinical part of that score had to be at least 4. On the other hand, there's more to this, because barely meeting those scores on a technicality is not enough. And we've figured that out by looking at all of the sort of barely there patients that have been participating in trials. So there was an adjudication committee made up of experienced lupus clinicians who reviewed all the entry data, and they had to be confident of 3 really important things. The diagnosis of SLE was accurate, reflecting, a patient with real autoimmune disease, that the disease was appropriately active to enter a trial of an investigational immune modulator or 2, and that there were no medical conditions, either from lupus or, comorbid conditions that might confound the assessments or put the patient at undue risk.
And tell us about those potential comorbid conditions, because I think that played into some of the exclusion criteria. Could you share those exclusion criteria with the listeners?
Yeah, these were the ones that were actually the formal exclusion criteria were, pretty standard in lupus trials. So you couldn't be triple positive for antiphospholipid antibodies, which puts you at high risk for thrombosis. And you couldn't have severe unstable lupus conditions such as, an unstable nephritis or very active nephritis or severely active neuropsychiatric lupus. But in fact, the adjudication committee did turn away some patients for varying reasons with varying conditions, where it was quite clear that these patients needed to be treated and should not get placebo. A lot of these patients were coming in on background medications, but if they had an unstable condition on top of that background medication, something had to be given to them besides placebo.
Yeah, it's a very good point, and always the challenge with studies that involve a placebo arm. You did randomize the patients to the treatment arms or placebo. So as you mentioned, there were 5 different groups. But at that point of randomization, there was a stratification based on baseline characteristics. Can you tell us about those characteristics and why did you choose to do that stratification?
Well, as I sort of mentioned before, these trials are incorporating patients on a wide range of background medications. They also have a bit of a range of disease activity, although we're working harder to make sure that that's not very low. So we have to do our best to find some kind of balance between the dosing groups for these variables. You wouldn't want all the sick people to be in the placebo group, the sickest people, and you wouldn't want, all the people on heavy medications to be in a treatment group, or actually to be in any group more than the others. So the stratifications were by baseline glucocorticoid dose, and that was a cutoff of 10 or less versus more than 10 milligrams prednisone or equivalent, whether the patient was taking an immunosuppressant, and that was a yes or no. And then the screening SLEDAI score, whether it was less than 10 or at least 10 or more. And then also by the interference score. So we didn't require people to have a high interference score to get in the study, but we wanted to make sure that the groups were balanced for those who had high or low interference scores. Remember, interferon can be a rough surrogate for disease severity and also happens to be applicable to the mechanism of these drugs.
Mm-hmm. Yeah, makes a lot of sense. So your study also incorporated a relatively unique, planned, unblinded interim analysis. Could you explain that to our listeners and help us understand why the investigators designed the study this way?
Well, if you can get in there early enough, which in this case turned out to be when 50% of the patients had either reached 24 or dropped out, then you may be able to have a little bit of a smaller trial, because if you do eliminate dosing groups, then you wouldn't be continuing to recruit in those groups. And we need efficiency in lupus trials. There are not enough trained trial sites. There probably are enough patients if we could only find them, but there are many drugs in development, and we're having trouble recruiting for these trials. So the purpose of the interim analysis was to be able to discontinue ineffective or any potentially unsafe dosing regimens. And this also saves the patients the necessity to participate in futile dosing groups. and keeps the dosing groups in there where there's a greater likelihood that meaningful data might be obtained.
Okay, so tell us about the outcome measures that you were evaluating.
Again, these are sort of de rigueur in lupus trials. They're used frequently. The primary endpoint, though, has been used in the past in phase 2 trials, notably the one for anifrolumab. But it's a combined endpoint that combines an improvement in disease activity along with the patient being on 10 milligrams of less of prednisone or equivalent. Now, if they came in on more than that, then they were being encouraged to taper down there by week 24. The improved disease activity was defined by the SRI-4, which is an improvement in SLEDAI without worsening by BILAG or physician's impression. Other endpoints were improvement in disease activity using a different BILAG-based assessment called BICLA, an attainment of a low disease activity state, which is defined by some rules that called LLDAS, lupus low disease activity state, which combines concepts of having a limitation of the SLEDAI score, stable disease, and no major organ involvement. We also did joint counts, skin scores, assessed flares, pretty much what is usually done in lupus trials.
Yeah, you also looked at a couple biomarkers too. Can you tell us about those?
Yeah, as part of the main protocol, the major biomarkers were anti-double-stranded DNA, complement, and the interferon gene signature.
Mm-hmm. And so even though this study began about 6 months before the pandemic, you were able to enroll 341 patients, which was more than, in fact, the planned sample size. What can you tell us about the cohorts? What were the demographics and the characteristics of the patients?
The clinical features at entry were pretty typical for lupus trials, even before the pandemic. And more than 90% were female. That doesn't surprise you, I'm sure.
Yep.
More than half were Caucasian, which is unfortunate, less than 30% Asian, and very sadly, less than 10% people of African descent. Close to 90% were on antimalarials, so that's good. Almost 40% were on an immune suppressant. And about half of the patients were on steroids, but 75% of those were on less than 10 milligrams of prednisone at entry. So it wasn't there. We really had a lower than usual low dose. And that's sort of been the trend as trials have been evolving over the years.
Yeah, we finally are getting to lower steroid dosing.
We're getting down a little, and that's good, I think.
Okay, so drum roll, please. What did that planned interim analysis show, and what happened next?
So the interim analysis, again, was performed when 50% of the patients had either reached week 24 or had discontinued, would obviously be considered non-responders. And what it showed was that some of the dosing groups were not efficacious. So it led to the discontinuation of the low-dose combined pill and the single treatment with elsubrutinib arms. So elsubrutinib alone or with low-dose upadacitinib were ineffective in this data, but there were no safety concerns. This was really a question of efficacy.
Yeah. So, and then the higher dose combination drug arm and the upadacitinib alone arm and the placebo arm then continued through week 48. What did you find at week 48?
Well, once everybody had gotten through week 48 and the data was all locked up and we were able to assess the data, the primary endpoint was a week 24 endpoint. And then all of the analyses that I mentioned before were examined at both week 24 and week 48. So we have lots of data. The primary endpoint, again, which was improved disease and achieving low-dose corticosteroids or staying on low-dose corticosteroids, was achieved by, in the placebo group, 37.3%. In the upadacitinib group, 54.8%, and that was statistically significant. And with the combined pill, it was 48.5%, so just a little bit lower than the upadacitinib alone. The SRI-4 alone and the BICLA and the LLDAS response proportions were higher for both upadacitinib and the combined pill versus placebo at both weeks 24 and 48. Flares were reduced. There were no new safety signals observed that had not been previously reported for upadacitinib or elsubrutinib.
Great. So I'm going to ask you to back up a tiny bit and go back to figure 2, because there is this great graphic that looked at flare risk, and flare is incredibly important both for the physicians and really, really a big issue for our patients. Could you share what those graphics show?
Yeah. So figure 2 is showing total flares and also time to flare over time. And they're also looking at severe flares and mild, moderate flares. The severe flare data in a trial which isn't all that large is very hard to interpret because we don't have so many of them. So you almost can't make too much out of that, although it looks like, you're better off on the active treatment arms. But for the mild, moderate flares, it's pretty dramatic. So when you look at total flares comparing placebo and upadacitinib, this is clearly, less than the placebo group. And it's also true with a combination drug, which doesn't quite reach the same height. If you look at the graph that shows time to flare, the 2 active treatment arms look almost identical, especially after 20 weeks. And again, we are showing a significant improvement, and it carries out throughout the whole course of the study compared to placebo.
And what about biomarkers? Did the treatments impact the double-stranded DNA or interferon signatures?
Yes. So there were decreases in anti-double-stranded DNA antibodies in those patients who entered with positive antibodies. And there was a pretty good amelioration of the interferon gene signature with both treatments. Upadacitinib is part of both of those treatments, or is the treatment of one of them, and it inhibits IL-6 signaling. So there's a known effect of IL-6 inhibitor drugs on complement production. So what we actually saw was the opposite of what you would want to see if you were improving lupus without lowering complement as part of your mechanism. We saw an initial decrease in complement, and that actually just returned to baseline levels later in the trial, but did not show any increase in complement. Now, the mechanism by which these IL-6 inhibitors decrease complement has to do with complement production. So there's nothing to do with what goes on in lupus, which is primarily complement consumption.
Yeah, and that's really good for us to know, because I think, if this moves forward, that is something important to not be alarmed about when you see it happening.
You would not get as alarmed. Yeah, that's right. That's right.
Yeah. So what can you tell us about safety? And we should point out again that this trial enrolled and was completed during the pandemic. There were, I guess, a couple of issues with COVID. Can you speak about the adverse events and then specifically risks of COVID-19 and other infectious events?
Yeah. Why don't I just start with COVID-19? Because we had 2 deaths from COVID. And I think that jumps out to people. I mean, my opinion in looking at that is that it was, especially since, remember, this trial started before the pandemic. So we were enrolling when there was no vaccine. We weren't sure how to take care of patients. I think 2 deaths is a very small number, but I will provide the sort of background information on that. One of those COVID deaths was from a patient who had been on the elsubrutinib alone regimen, and then that was stopped. And the other was from the combination treatment. So both of the COVID deaths were in patients who are receiving elsubrutinib. I don't think you can conclude anything from that, however, but that's what it was. But my role in the study was quality assurance of the entire trial. So I was monitoring all the data in real time as it was coming in. My role was really about scoring disease activity, not safety. But I was aware of which parts of the world were recruiting at any given time. Now, when we started, we had no idea what was going to happen when, COVID hit. So we started seeing sites shut down in different parts of the world, and we were preparing for disaster. And I actually thought that we were going to have to shut the trial down. But we were taking it day by day, and people were recruiting in certain parts of the world where COVID really hadn't penetrated that much. And there were also 2 things at that time we didn't know. The first was that lupus patients on all of their varying immune modulating treatments are not quite as high risk for severe disease as we'd originally thought they would be. And the other thing we didn't know yet was that a year or two later, baricitinib, which is after all a JAK inhibitor, started being used to improve the prognosis of really sick COVID patients. So I'm not going to suggest to you that there was nothing to be concerned about, but just that the actual facts are a little more complex than we even understand now, but certainly understood at that time. So what actually happened was that as the time passed, some of the sites that had originally shut down opened up and started enrolling. Some of the sites that had started enrolling had to take a pause. They didn't necessarily kick their patients out, but they weren't enrolling new ones. And we were watching these waves of COVID go around the world several times. And not every area was as bad as every other area at any given time. I think that's how we made it through. To summarize the safety data, other than that, there wasn't much neutropenia or lymphopenia to speak of. Serious infections were, not surprisingly, increased in the active arms. And herpes zoster was increased, particularly in the combination drug. So that was 11.8% versus 6.5% in upadacitinib and 4% in the placebo. Total serious adverse events, however, were lower in that combination pill group. So that was about 10.3% had serious adverse events in that group. And in the upadacitinib group, it was 21%. And in the placebo group, it was 17.3%. And there were no malignancies or adjudicated venous thromboembolic events. Total of 3 deaths. The other death I didn't tell you about before was a drug overdose.
Yeah, amazing story of keeping this study going throughout the pandemic. And I just very grateful that it was able to continue through the pandemic. So towards the end of your manuscript, you explain some of the challenges in previous lupus trials, particularly regarding the high placebo response rates. Could you walk us through some of those challenges and then how in particular you'd address them as you were helping design this study?
Well, for more than 20 years, almost all trials in lupus failed to show any difference between treatment and placebo. And we were beginning to understand that if you have a placebo response of over 40% and you're trying to do a trial in lupus where the patients are heterogeneous, you can't expect even an effective treatment to get these stringent responses in more than 50% of the patients. And so your trial's going to fail. So anyway, we kept doing these sub-analyses of all these failed or disappointing trials. And what we would often find is that there would be some subset of patients where the placebo response was lower than 40%. And we would find that the response to active drugs didn't go down as much. So that if that population alone, which was now found by cherry picking the data, if that had started out being the whole trial, the drug would have looked effective. So it became understood that our placebo responses were just too high, and that although all these drugs had been put back on the shelf, we were not able to say they worked, but we were also in a position where you couldn't really be sure they didn't work. So we had other issues that we identified. Some of the patients coming in the trials had bare minimal disease that barely met the thresholds for the scoring rules, and the scoring didn't always make sense at the sites. There was an issue with training at all the clinical trial sites. And also there was the suspicion that our patients were on too many complicated regimens of various combinations of background immune modulating treatments. So in 2018, the Lupus Foundation of America supported a project with lupus investigators and advisors from drug developers who got together to look at the data that had been accumulating, all the published data, and try to analyze the problems. And it was pretty simple. 1, polypharmacy was a problem in these trials. 2, sick enough patients was a problem in these trials. And 3, data quality was a problem in these trials. What I just said. But formally looking at the data, that's what it showed. So the way in which this trial and several other recently successful phase 2 and 3 trials in lupus have addressed this is by really more encouragement in the tapering of steroids, adjudicating the disease activity of the patients at entry, which I did sort of mention before. And finally, and this one's the draconian one, having experienced lupus trialists literally monitoring every data point instead of just a nice a nice, competent person from a CRO who doesn't really get the nuances of what makes sense in lupus. So what this did in a number of trials now is it's lowered placebo response proportions to quite a bit less than 40%, sometimes between 25 and 35%. And this gives an effective treatment a fighting chance to show a difference.
Yeah, I think so important to bring out those differences.
Yeah, there's one more thing. We now know that placebo responses will be lower without so much effect on the treatment responses if there is a combined endpoint that requires improved disease activity and also a low steroid dose. And so that was reflected in our trial in the primary endpoint.
Yeah, I mean, I think so many lessons learned and an impressive story of the whole community really coming together to sort of adjust how they're running trials in lupus, and really impressive that you've made such an impact. So, Joan, I want to pivot our discussion a little bit away from clinical trials for a moment and shine a spotlight on you, because you have been a powerhouse in rheumatology, but you didn't always plan to be a rheumatologist. There was a time when you were in the spotlight on a different stage. You originally majored in drama at Vassar College, and after college, you actually trod the boards in several off-Broadway productions and some movies. Tell us about that early period of your career.
Well, I keep coming back in my head to a song from a Broadway show that was about women in the follies. But I sort of always saw myself as a person with a great deal of folly and pounding around Broadway trying to get a job. The song goes something like this. At my tiny flat, there's just my cat, a bed and a chair. So I was one of those ubiquitous New York waitresses who was really an actress with holes in her shoes because all I could afford to pay for was the exorbitant rent on my rodent-infested Manhattan studio. But those were great days. We were able to go and see the second act of every Broadway show in town for free. They used to let you go in for free at the second act. And the idea was that you were allowed to stand in the back. But of course, if there was an empty seat, we took it. And then eventually I just got tired and I decided with my infinite wisdom to do something that to me looked easier, like going to medical school.
So how did you pivot from acting to medicine?
Oh, actually, there was a real moment. I used to fall asleep with my radio on, and one night I was jolted awake by this voice. It sounded like in one of those movies from the time of Jesus. You'd hear this big voice in the sky. It sounded like a big voice in the sky, a very deep man's voice, and it said, "Don't you wish you knew more about the world in which you live?" And I thought, yeah. And then it said that it was going to sell me a subscription to Scientific American. And I actually got a subscription to Scientific American, started reading this sort of, that was a magazine that would just tell you what's going on in science, but kind of make it accessible to the lay person. Really, I knew nothing about science, so at first it didn't seem all that accessible to me. But I waded my way into it. I became mesmerized by science. And then another thing happened. I went out to dinner with a friend who was an actress, and she was fed up and she wanted to get out of that business. And she said she wanted to be a paramedic. She was going to go train to be a paramedic. And I started really getting on her case and saying, why don't you be a doctor? You should be a doctor. Why stop at paramedic? Be a doctor. And she's like staring at me, like shaking her head. And suddenly I realized, oh, you don't want to be a doctor. I want to be a doctor. And that's when it happened.
So I love it. And I'm sure Scientific American is very happy that you just gave an amazing advertisement for their magazine. I like that there was a voice of God involved. That's cool. Yeah. What ultimately drew you into the field of rheumatology?
Well, that happened when I was passing a bulletin board in medical school, and there was a sign on the bulletin board inviting people to do their one of their fourth year rotations at the NIH. And so, of course, I went immediately to my dean, got permission, called the phone number, And the next thing I knew, I was down in Bethesda, Maryland, walking into the lab, and it turned out that the whole thing was a hoax. It wasn't really a hoax. It was the fellow of Dr. Steinberg, who was a very, a pioneer in murine lupus. But it was his fellow who wanted help so he could study for his boards. And there was nothing official about it. So they were about to send me home, and Dr. Steinberg decided that I could stay. So I stayed in the lab doing all sorts of work with mice. And it was all about lupus. And I guess the rest is history.
Amazing story of sort of serendipity and chance encounters. I love it. Yeah. So you are a New Yorker, but in 2001, you moved from New York to the amazing Oklahoma Medical Research Foundation. What prompted that move, and how has that shaped your career?
Well, what prompted the move was that I was a refugee. So I was working at St. Luke's Roosevelt Hospital in New York, and it turns out, I just want to give you the end of the story. About 5 years later, I read that the head of the purchasing department there was jailed for theft. But at the time, I didn't know that. And I had painstakingly gotten the money together to bring in a real basic scientist for a really cool project. And I'd gotten him a lab, and he told me he had to order a great big fancy freezer for close to $20,000. And I scraped it together and, we ordered the freezer. But apparently the purchasing department ordered 20 freezers for $400,000 and charged me for all of it. And when I tried to straighten it out, I was told that my signature was on the order. So, of course, I then asked, where are the other 19 freezers? And the answer to that was, I'm sorry, but, deliveries is not what we do.
My goodness.
So I had no money to pay my scientist. They made me fire him. I was clinically depressed. Soon after that, I happened to be at a lupus meeting, and I gave a little talk for about 10 minutes. And in the audience was John Harley, who immediately invited me to Oklahoma to give a talk. Now, his presence at that lupus meeting was particularly fortuitous because they were very unimpressed with the talk I gave in Oklahoma. They thought it was bad. But Harley had seen the other talk, so he got them to hire me anyway. And I ran screaming away from that situation in New York. And how it shaped my career is that once I got to Oklahoma, this was the good old days. It's not true anymore, but for about 10 years, I was on a hard salary and nobody paid any attention to me. So I got the kind of protected time that no person gets these days. I was able to make my mistakes and build a research program. By the way, in Oklahoma, we are in a position to provide something almost that good to some young person who might be interested in developing precision medicine for rheumatoid arthritis. So if you are that person and happen to be listening to a lupus podcast for some odd reason, please call me.
Always good to put in a plug. And I've heard that in Oklahoma they have more than 20 freezers, right?
Oh, yes. Well, that was part of the inducement. John Harley made it very clear I could have all the freezers I wanted.
So tell us about the mentors who helped you on your journey.
Well, either I've been very lucky or I'm very pushy, but I've had a lot of wonderful mentors. I mean, I hope I don't forget too many of them, but there was Bob Winchester, who does not communicate very well in English, but he taught me to speak, fluent science. Jill Bion, of course, one of the most creative thinkers in rheumatology. Bob Lahita, who just had this joy about science. John Harley and Judy James. I could go on and on about their brilliance, but the real lesson is how relentless they are in pursuing the question. And then Bev Rahan, the groundbreaker, who, is a very no-nonsense person and does not suffer fools gladly, but she loves everybody and she supports everybody as if she was their mother. There's so many.
Yeah, and I will say kind of that's one of the beautiful things about rheumatology is that there are all these incredible mentors in our field. So how do you think your previous training as an actress helped you as a rheumatologist and particularly in research?
Well, Shakespeare said it best, all the world's a stage.
I love it. So you have really been effective in reshaping how clinical trials in lupus are designed, and particularly this concept of weaning the background therapies so that you can really show efficacy. You've really built amazing collaborations with patients in clinical trials and worked on recruiting more underrepresented patients to trials. Have there been any times where you yourself felt like giving up, and what kept you going through those hard times?
Yeah. Of course, there were times I felt like giving up. And I'll bet there were times when you felt like giving up. But what kept me going, I think, was desperation. I remember one time I was at the ACR meeting and I was feeling somewhat suicidal because probably nobody came to my poster, and I had had a paper rejected from the third journal, and both grants that I'd submitted were triaged. And somebody I knew in fellowship training came up to me and said, "Wow, how did you do it? Your career just took off and it was so easy for you." And of course, I didn't have any answer from my friend because I was doubled over hysterically laughing. So, of course, that was desperation, but really, fun desperation.
Well, so it's definitely true. I think that sometimes things look easy from the outside, and in reality, they are not. So, Joan, I really want to thank you for talking to us today, for sharing your insights and your wisdom, and most of all, for not giving up, even when times were hard. Thank you for all your hard work trying to improve the treatment for patients living with lupus.
Well, thank you for your really thoughtful questions. And let's also thank the patients who enroll in clinical trials. It's such an enormous commitment. And of course, we won't get better treatments without this incredible contribution from people with lupus.
Oh, well, I appreciate you saying that, because that was going to be my thanks to all the patients. We really are so appreciative of people who enroll in clinical trials and how they impact discovering new treatments. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at ACRoom on social media. Email us at podcast@rheumatology.org, and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.